Good afternoon, ladies and gentlemen. I welcome you all to Eyezone webinar series. I'm Snehal Sawant, Executive Editor of Eyezone and your moderator for today's webinar. It is wonderful having so many members of the vision care community joining us today. Today's topic is Eye on Vision Screening, Insights and Approaches. The webinar series is an initiative of Eyezone Education, and our mission is to empower eye care professionals with knowledge from industry experts on topics pertaining to vision care. With that, may I invite Eyezone CEO and founder, Mr. Ali Bandur, to deliver his welcome address. Over to Mr. Ali.
Dear colleagues, greetings from Kuwait. For over 15 years, Eyezone has been continuously broadcasting valuable information and resources to the optical industry in the MENA region. It is with high spirits that we enrich our readers' knowledge of current events and research and contribute to the growth of region's eye care. It wouldn't have been possible without the support of our vast network of eye care professionals, organizations, and businesses. And for this, I would like to extend to you my huge gratitude. I would like to take this opportunity to welcome our distinguished speakers for today, Professor Kovin Naidoo, Dr. Ali Sharifi, and Dr. Naima Khan, with whom we are crossing virtual paths to open doors for innovative ideas. My heartfelt thanks for your generosity and kindness, as well as your staunch support of access to comprehensive eye care for everyone. I would also like to acknowledge the presence of our dedicated eye care professionals who have joined us in this event. This initiative is one among our many ways of paying it forward. Today, Eyezone Education is bringing you an event in light of the World Sight Day observance last 14th of October, promising to enhance the potentials and broaden the avenue of discoveries for our region's vision experts. Through this webinar, we shall discuss key information and fresh perspectives on vision screening for children and adults. Conducting accessible eye exams, especially among children, should be a top public concern. Promoting vision health should be everyone's responsibility, as it plays a crucial role in shaping the future of our communities and humanity in general. Through the wealth of knowledge exchanged by our regional and international vision health specialists, our way of identifying vision disorders and potential treatments may find a new window of opportunity and deepen our approaches to eye and vision care altogether. In this webinar, we demonstrate our optimism that our vision health care shall be lean toward new insights and continue breaking grounds with every aspect of this practice. On behalf of the Eyezone team, I would like to welcome you all to Eyezone Education's Eye on Vision Screening Insights and Approaches. I wish this talk and our collective efforts serve as useful compass in navigating the future of vision care for generations to come. Thank you and all the best to everyone.
Now, let's move forward into our main session today that you have all been waiting for. There are 3 speakers who will be addressing the audience on various aspects of vision screening. The entire session will focus on the various screening strategies as well as alternatives or innovations. It includes significant talks on issues concerning access to comprehensive eye care. The keynote address will be delivered by Professor Kovin Naidoo, followed by presentations by Dr. Ali Al-Sharifi and Dr. Naima Khan.
So thank you very much to Eyezone, the CEO, and the staff for inviting me to this presentation. We have two colleagues who are going to speak about the specifics of children and screening, and so I'm going to try to stay away from that so that I don't overlap them. My role today as in this keynote is to give you a sense of what are the challenges in terms of the old refractive error space, which we know is driven by, particularly driven by myopia in children, and what we need to do to create access. And the colleagues will speak more specifically about how we practically go about that. Okay, so I just want to start by looking at refractive errors. And in the last 20 years or so, the global burden of disease studies have shown us that blindness and vision impairment has decreased in our world. Okay, and that's a very positive sign. However, what they've also shown us is that refractive error is the second leading cause of blindness. And this is the orange part of this graph, which is about 20%. It's about 20%. And in the leading cause of moderate to severe vision impairment, which is more than 50%. Okay. Now, why is that relevant? Is that if refractive error is such a big driver of this vision impairment and blindness, the progress and the success that we've had thus far is at risk. And the reason it's at risk is, sorry, I just want to put my stopwatch. The reason it's at risk is that myopia is increasing significantly. And some of you may have seen the paper that we published where we showed that by 2050, half of the world's population will be myopic. Okay. Now, the question often arises in my region, is it such a big problem, etc. Now, this would happen if we don't do anything. It's not factoring in myopia control, but by all indications, myopia control will reduce this number, but not that significantly, especially if we don't create access in the developing world. So if you take like Africa, even though Africa may be starting off on a low base at 7% of myopia, by 2050, it will be a 4-time increase, 28%. And current resources are not enough, okay? So as a result, we know that myopia is positioning itself to be a spoiler of the successes that we have made in blindness prevention globally. And we know that the only way to deal with this is to have a comprehensive child eye health program that can include myopia control and early intervention. Because we know that research is showing that the quicker we get to children, the better it is, that some even conventional myopic correction is better than no correction, and that myopia control interventions are achieving as high as 55 to 60% in some cases, where we can keep children away from developing high myopia, which I will talk about. So if we look at North Africa and Middle East, and given the audience today, I think it'll be interesting to note, in 2000, we had 14.6% of myopia. But by 2050, that would be 52.2. We know this region is a highly developed region. And as a result, we are going to mirror much of the developed world, which is like Europe, Australia, America, etc., who are going to be more than 50% by 2050. But the most concerning thing is that nearly 1 billion will have high myopia, which is 20% of the myopes. And the problem with eye myopia, as many of you would know, is that eye myopia will lead to certain complications, which have the potential to create permanent vision impairment and blindness prevention. I don't have the time in this to go through all of that, but I think that most of you are well aware of these conditions: staphyloma, glaucoma, cataract, early onset cataract, retinoschisis, retinal detachment, but most importantly, myopic macular degeneration. And we've seen in some societies, especially in Korea and in East Asia, it's starting to show that myopia macular degeneration is actually becoming one of the leading causes of monocular blindness. And it's a matter of time before it becomes a leading cause of bilateral blindness. And a couple of years ago, if somebody told me that, I would have asked them, what are you smoking? Because quite frankly, it was always about cataract. It was always about glaucoma. So myopia is becoming much more a major part of our lives. And one of the biggest challenge we have in our world is that we are not going to be able to deal with myopia if we don't address the number of people that don't have access to services. And we know that uncorrected poor vision is a public health crisis today, right? 1 in 3 or 2.7 billion people suffer from uncorrected refractive errors, simply not able to get access to a pair of glasses and an eye exam. And we have to address the ecosystem of refractive errors if we want to address the increase of access to children, because we know that when the overall refractive error services are improved, that's when children benefit and children's services improve. And there are strong arguments for this. We know about the social and economic impact of uncorrected refractive error. $272 billion in lost productivity was the initial paper we published. But more recently, last year, we published a paper where we showed that from myopia alone, there's $244 billion per annum in lost productivity that's happening, which means society is losing dollars as a result of not addressing myopia. And we are not adequately factoring in the impact of high myopia when we're going to need treatments, surgical treatment for myopia macular degeneration. We're going to need ophthalmologists' workload to be increased, which means more human resources, etc. So we're heading for a big crisis overall. However, there's positive news. We've seen that the Global Action Plan of the WHO started talking about refractive error in a more significant way. And in fact, I was on that editorial committee, and there was a challenge to just get the word optometrist into that report. Unfortunately, as the committee that put that Global Action Plan together, we were able to quantify the need for optometrists and get that there. That was a turning point in the development of optometry, but also uncorrected refractive error. The Eye Alliance report spoke about spectacles, and it's a very useful report to have a look at. And more recently, the World Report on Vision came out. And the irony is, having served on the editorial committee of the Vision Global Action Plan and the World Report on Vision, in the World Report of Vision, the role of optometrists was a non-issue. The importance of refractive errors were a non-issue. It was just taken for granted that these are major drivers of any future eye care strategy. The need to provide eye care services for children was immediately accepted. And therefore, this report for optometry and for refractive errors in general is an absolutely good report, because it is a great advocacy tool that can be used to influence our governments in the Middle East and all over the world in terms of to push them to invest in optometric services, but as well as to invest in refractive services. The World Health Assembly endorsed refractive error as a priority, and that resolution again saw that refractive error is now sitting alongside cataracts, whereas before it was mainly cataracts and other. That was the term, but now it's cataracts and refractive errors, and that's a significant development. And more recently, the UN passed a resolution saying that by 2030, at least 40% of the problem of uncorrected refractive error needs to be addressed, which means that governments are going to have to report back to the United Nations on these issues. And this is a major development for us, and it's important that we contextualize child eye health within this broader target set by the World Health Assembly as well as by the United Nations. And that is what is going to push governments to make a greater investment. In ESULO, sorry, I forgot to mention my conflict of interest. I am employed by ESULO, so I think it's important for you to consider that as my declaration. There's nothing in this presentation that's pushing ESULO products, but more the public health aspects. But I needed to declare that, and I forgot at the beginning. Sorry about that. So in terms of helping set the global agenda and drive support around the cause, ESULO came up with a report called Eliminating Poor Vision in a Generation. And this, we worked with consultants who assisted in ensuring that we can make the case more efficiently. And the reason is nobody dug as deep as this in terms of refractive errors. Now, the numbers are different. When you read the World Report, you'll see it's about 900 million that they talk about when you take out some of the other causes. But in the ESULO report, it is more about 2.7 billion. The reason is we did not use 612. Now, when 612 was set as a cutoff many years ago, and in fact, I was privileged with Brien Holden to be at that meeting for the first refractive error working group meeting that the WHO hosted. And 612 was set because it was felt to be realistic for governments to achieve when there's little resources. But when you use a 6.9 cutoff, right? In many places it was actually 6.18 that was used in that track. But it was less than 612, which is basically 680. But we know that we are often getting individuals in practice who come to us for refractive services with 6.9 and they can't function. So in the SLO report, we use 6.9 as a cutoff. And that showed in 2018, 2.7 billion people will have cannot access eye exams and glasses in our world, which is a major public health crisis. And if we want to do anything, which is by 2050, we have to accelerate everything that we do. When we look at the number of people with refractive errors in our world, it's going to go from, in 2018, from 4.7 billion to 6.6 billion in 2050, if we don't do anything, okay? And we noticed that Middle East and Africa here and Asia are going to be the major drivers of this change, because in these areas, the prevalence has started off lower than most of the developed world, but is going to accelerate significantly. So here we are, the 2.7 billion people. And if we don't do anything, we'll have 2.5 billion because we'll have organic growth of what we're doing. But the reality, if we continue, if we maintain the current focus and don't even expand and don't have that organic growth, we'll have 3.2 billion people with uncorrected refractive error. However, if we expand and have the growth, current growth that we're having, we'd have 2.5 billion. But if we bring everyone together and be innovative, what the bottom graph shows us is that we can get rid of URE by 2050. It is not impossible to get rid of URE. So those are the three scenarios. Here, what I want to show you that it'll cost $14 billion for philanthropy, inclusive business, etc., for us to be able to address this issue significantly. And if you consider that our annual loss in loss productivity in the world is 272 billion, we need to have awareness, acceptance, we need access, and most importantly, we need affordability if we are going to effectively address the challenge of. And what this slide tells you is that you need all sectors to be involved. We need the public, private, we need to get everyone together, and we need the private sector optometrists who at the moment and companies to deal with providing for those who have the resources. So there are a couple, and I'm not going to go through all these details because I have very limited. When we look at child eye health programs, you need to look at these different aspects when you're developing this program. Just arranging a screening program and say, I've gone to school and I've made a big difference is not enough, okay? We need to have proper service points with optical service providers, because when your screening program is over, they need to have a referral point. We need continuous service for children because we know their prescriptions changes. So the target is that everybody should have an optical shop or an optical service point, at least within 1 day's travel. They can go to it and come back home in that same day. And that is the target that we need to look at. We need to have affordable solutions. We need to funding gaps in affordability and access. So for example, we need subsidized services. We need philanthropy. We need to ensure that the poorest of the poor who cannot afford any services, that funds are provided. And then we need to add tailored information campaigns. We know that sometimes when we set up these programs, people don't come because they're not aware of the campaigns. Okay. And these are some of the issues we need to look at. Service points, affordable solutions, funding gaps I've spoken about, but we need tailored information campaigns, right? Looking where we target local governments, NGOs, we target the society in general. We need coalition of partners. No one, business can't do it alone, government can't do it alone, Everyone needs to come together with NGOs, etc., to make this happen. And we need robust data that we can use to go back to the UN and say, this is what we achieved, or go to government and say, this is what needs to be achieved. And as a result, this is what investment you need to make. So after I left Brien Holden, myself and Matt Holding came together and we formed what was called we initiated what was called the Global Myopia Awareness Coalition. And most companies are part of this. And through this coalition now, we are investing almost $1 million a year that we've raised, that we are now in creating campaigns to inform the public. We've started in the US, we're now going to the UK and Europe, and we're going to expand to other parts of the world. Educating parents about myopia, about time outdoors, all of those are critical parts of what addressing this crisis is really about. And we also, with the SLO and IAPB, we initiated the URE Coalition, the Uncorrected Refractive Error Coalition, which has been now called the Clear Vision Alliance. And we brought all the NGOs, as many businesses are coming together. We are talking to professionals. So World Council of Optometry hosts this organization, the American Academy. We're talking to as many different entities as possible to bring them to the table so that we can all work together in a coordinated way to be able to address the need for refractive services. We're going to have to do a lot of fundraising from foundations and wealthy individuals. We need to raise about $330 million per annum in philanthropy if we want to eliminate URE by 2050. The big challenge is, we know that we say optometry is the major part, but there's a shortage of optometrists. And as a result, we need to think differently. Our global mapping study showed that only 26.8% of the countries in the world reach a ratio of 1:10,000 optometrists. And we know that in some countries, in Africa in particular, there's 1:1,000,000 is the ratio. We've set up the Global Ophthalmic Institute, and part of our objective here is to start supporting the expansion of schools of optometry by getting people in the developed world to conduct lectures remotely so more schools can be set up, higher quality, greater volume of students, etc. We need to think about teleoptometry and other interventions. We saw in the US that teleoptometry during COVID became used widely. We know that we're not going to train enough optometrists at the rate that we are producing them. We need to link up with primary vision care providers or technicians and look at how teleoptometry can reach rural and underserved areas. If we don't, mark my warning, optometry is going to become obsolete in this world. Eventually, the myopia crisis is going to necessitate other human resources taking over our role. And this allows us to achieve the last mile connectivity. We know our colleagues are very resistant to going and working in rural areas, but let's look at whether we can now link them up with a rural technician where they eventually sign off, they control the process. And these are things that we have to look at. School eye health programs are a bit different. We need to get to the children because we need to do cycloplegic refractions. So if we can, through that network, generate the interest, we'd have to think creatively about school eye health programs in terms of outreach or getting optometrists to rural areas, because it's much more complicated. And I'm sure my colleagues are going to speak about it. We worked with the IMETRA model, where we train primary vision care providers in India. And now we are linking up optometrists via teleoptometry to provide oversight, observe the eye exam, sign off on the eye exam. And now with technology like low-cost fundus cameras, pictures can be taken. Those can be relayed to an optometrist, and the optometrist can be able to sign off. We need to look at innovation in terms of, I spoke about telerefraction. We need to look at easy to use and accurate measurement tools like the click check that we've developed, which is basically costs $50, but it does the same thing as what an auto refractor does in a less fancy way. And these are the things we need to look at. We need to look at how we can create supply chains via technology, because in many rural areas and underserved countries, there is not enough access to spectacles that exist. We need to look at how the public-private partnerships. And in Kenya, we're working with the Kenya Society for the Blind, where we are able to, in partnership with them, establish optical shops in government hospitals that optometry is involved in. that the government is involved in, that SLO as the private sector partner is involved in, and this has also already created access in some key centers where eye exams are being done, but no glasses provided. And we need cheaper and affordable, we need good quality, affordable spectacles, like the ready to clip that we've developed, where you can clip in different power lenses, but we need to look at even ophthalmic frames. The cost of eyewear is not going to solve this problem, the current cost, especially for those who don't have. We need innovation in training. I've spoken about that. And essentially, we need to create sustainable access points. We need to innovate for affordable product. We need to fund or subsidize free services. And most importantly, we need to raise awareness, particularly amongst parents in relation to children, given the myopia crisis. The reality is myopia is pushing us off track. We need to get on track to eliminate uncorrected refractive error from the world by 2050. And if we don't look at this in a comprehensive way, and I've tried to in the short time race through this and give you a sense of it, the reality is that history is going to judge us very harshly as optometry, because we would have promised the world that we would serve them in a particular space, but not achieve what the world demands of us. Thank you very much.
Okay, great. First, I'd like to extend some thank yous to Eyezone for hosting this great event. It's a unique way to get different perspectives on vision screenings. I am an optometrist practicing in a government-run hospital in Kuwait. So that's kind of my perspective, and I have no financial disclosures to make. So with that out of the way, let's go ahead and go to the next page and discuss what we're here to do, which is discuss vision screenings. So the screening is just a technique to test for the presence or absence of a disease or whatever it is that you're trying to check in the population. So in our case, we would like to check a reduction in visual acuities or visual function, and that's done initially by performing a vision screening using validated procedures and tests. Our mass screenings should be efficient, as many of co-hosts have mentioned. You want to do the minimum number of tests to achieve the desired goal. So you're not there to prescribe glasses, let's say, or prescribe contact lenses, or you're there to discover, to find out whether or not this patient or child, or adult for that fact, is within normal limits for their vision or not. Okay, so first goal we want to identify is, do we have abnormal vision, yes or no? And most commonly, it's due to refractive error, so hyperopes, myopes, astigmats. But you can also have amblyopic amblyopes, so they might have strabismic or refractive amblyopia. Those are another common causes for reduction in vision. Of course, organic disease is a big one. You can have early cataracts or glaucoma. You might have some corneal opacities, retinoblastoma. Unfortunately, you get many of those things. So you want to, during this process, when you have a reduction in vision, it can be to any number of factors. And you're just at the very beginning of this whole testing process. So our screenings are our first line of defense. And so you want to, if detect a disease early on, you can treat it, or if you have amblyopia, you can treat it early on. And perhaps, if you have something more serious like retinoblastoma, you can detect and get that treated and save the person's vision and life. So that's why it's really important. So again, amblyopes are generally 2 to 3% of the population. You want to catch those early because you want to treat amblyopia before the age of 5 if you want to get some good results. After the age of 5 years, it's generally more difficult. Again, with amblyopes, you can have refractive amblyopia or strabismic. You can have deprivational amblyopia, where there's something blocking the visual axis. It can be a ptosis of the lids blocking the visual axis, so you prevent an image forming on the retina. It can be from a corneal opacity or a cataract that's obscuring the visual axis, and so it can be due to many causes. And so again, we want to initiate treatment as early as possible in order to save the person's vision. That's just a little bit on refractive amblyopia. We always most commonly think about asymmetric acuities being caused by unequal refractive errors, but you can have bilateral more symmetrical reduction in acuities when you have a large amount of bilateral astigmatism or a very high myopia that's similar in both eyes, and or hyperopia that's similar in both eyes. So all of those are possibilities. So in having a successful vision screening, it's really important not just to flag the patients that need referred, but also to have a system of communication with the parents or guardians of the child, explaining why it's important for them to get their child the follow-up care that's needed. It's not just just flag them and send them out the way. You have to make the parents understand why it is important for their child to be seen at that point. And so, in addition, there should be a successful, there should be a communication relay of network, like from the eye care practitioner back to, let's say, the screening school or nurse or whatever it may be, saying that this patient was seen and that we know that the patient was seen and maybe they got treatment initialized. And they should, many of the schools will will get a note back from the doctors saying that they need glasses. They should be wearing glasses in school. But maybe it could be a low vision patient, and this patient may need actually some more care. And there should be like a note saying that this patient has low vision needs, and they can be they need to be sitting up front. They might need to use a portable electronic magnifier or some sort of dome magnifier, or perhaps a telescope. So each patient's different and unique, and so they need to be treated that way. But it's good to have a communication system informing the patients why it's important for the child to be seen, and from the ECPs back saying, okay, this patient was seen, and this is what our recommendations are. As far as having a successful training program, you need also the staffing to be trained prior to the day of the testing, so that they are familiar with the best strategies in developing, in testing children or adults for that fact. So some countries do have this formalized trainings or certifications, and others don't. But whenever you're doing this, it's a good idea to have your staff properly trained in order to be as efficient as possible on the screenings. Okay. Beyond that, we can have some obstacles besides staff training that may reduce our efficiency during our exams. And so one of them is the cooperation of children. So you want to make sure that if you're doing this test, that you're doing it in a place that's free of distractions. So you want, in order to get the child to cooperate, you should minimize the interaction with whatever it is in the surroundings. So in terms of especially young children that are under the age of 5, if you're doing your vision exam, you're using a traditional optotype or visual acuity chart, try to maintain the distance or keep a distance at 10 feet or 3 meters. That way they're less distracted. Also, organizing your equipment before you go to the exam is going to save a lot of time and effort, and also make sure, I think Dr. Naima mentioned it earlier, if you're in a location that doesn't have a power supply, you make sure that you have your batteries charged up beforehand, or that you maybe instead of doing it, you might be forced not to do instrument-based screenings if you know you can't set up a system where you get your equipment charged in time. There are some. I'll be discussing this a little bit later on with the portable electronic screenings, and some of those are battery that can be charged by batteries. But we'll get to that here in a little bit. So obstacles of vision screenings: time, staff training, cooperation of children. So make sure you choose an appropriate environment. Let's go to the next slide. Okay, so when should we do screenings? At what age? So the American Academy of Pediatrics recommended a vision screening schedule that starts within the first essentially 3 years of life, or 2.5 years. So between 1 month and 30 months, they should be screened at least once, whether it's at an eye care professional's office, that's pediatric ophthalmologist, pediatric optometrist, depending on how your the area of location of practice where you are in what country, what you can and what can't do, but or at a pediatrician's. So that's the first period, so between 1 month and 30 months, and then tested again at ages 3, 4, and 5. And beyond that at ages 8, 10, 12, and 15. So generally the first few visits during those first screenings, those are primarily to catch amblyopia. Beyond the age of 8, hopefully if you have a successful screening program that's done yearly on your children in school and whatnot, that you're just going to be concerned about detecting refractive errors changes. So the first few years of life, your asymmetric prescriptions, your anisometropias, those should have been already caught. Your strabismics should already been seen and treated. God forbid, some diseases inside the eye should be already diagnosed. And beyond that, so beyond the ages of 8, 10, 12, you're checking just essentially refractive changes. And there unfortunately diseases do happen. So you want to also screen for those. So that's where this program sets up. Okay, so who should we skip screenings altogether? So we recommended that, we want to do screenings on children of different ages, but there are some children that can be referred directly without the need of having a school screening. So any child or patient with an obvious ocular abnormality. So if the patient has ptosis or strabismus, those should be sent right away. Children that are premature, diabetic children, children with juvenile rheumatoid arthritis, or those with neurodevelopmental disorders, including autism and Downs, those should be sent right away. Also, if you have like the parents or teacher that are significantly concerned about the vision of a patient, those can also be sent directly. So what encompasses an exam for infants or newborns? That first exam period that we discussed from 1 month to like 35 or 30 months. So that's a basic screening to check if the child can fixate and follow lights, if their pupil responses are normal, if they have any ocular alignment issues, so like if they have a strabismus, they might have an esotropia or exotropia, and it's also recommended they get a basic ophthalmoscopy done, so a basic fundus exam done. So this is generally done at a clinic or a hospital setting. When we're discussing about screening programs, generally we're discussing about the ages of 3 and above. So that's when we discuss the mass screenings. So the mass screenings begin at the age of 3, essentially, and beyond. And there are generally 2 techniques that were mentioned by earlier guests. So photo screening or auto-refraction based screening techniques, those are gaining more and more popularity because of their simplicity, or the acuity based, which is the golden standard. And it depends on what you have available to you in your practice. You may be able to do a combination of both, but usually if you're limited on resources, you want to do like one test. The one test that should screen the population and catch as many patients with abnormal vision as possible. So if you're going to do one test, it's going to be either a distance acuity based vision screening, or you can do your photo screenings or an auto-refraction based test. So we'll go to the next slide. For the auto-refraction and photo screening, in fact, those techniques have been getting so much popularity that Prevent Blindness recommends this technique be used in association the American Association of Certified Orthoptists and the American Association of Pediatric Ophthalmology and Strabismus and the American Academy of Ophthalmology on children like 12 months and older or preverbal children. These techniques are very good. Using an automated screening technique can really give you a quick check on whether or not they're normal or not. And it requires minimal cooperation. In fact, we'll discuss it here in a little bit. They're very, very fast. And it takes seconds to get done. As far as what equipment is available, the Prevent Blindness organization, they recommend 4 devices that have been shown clinically to be able to detect a fair number of patients successfully. So the oldest two devices are the autorefractors, the Retinomax and the Welch-Shallon SureSight. So those two are done monocularly. The Retinomax, you do have to be close to the patient in order to get them to check. It has to be within a couple centimeters. But the Welch-Shallon SureSight, you can do it at a distance of about 30 centimeters, if I'm not mistaken. So those are the two older ones. The two newer ones are the Welch-Shallon Spot Vision Screener and the Plus Optics Vision Screener. And the nice thing about the newer devices is that they're done binocularly and at a distance of about 1 meter. Again, when we're doing these screenings, the patients are not being cycloplegic. This is a dry autorefraction of sorts. Okay, so and you just want to gauge whether or not this patient's visual system or refractive system is within normal or not. I guess one of the flaws would be with using these automated instruments, you don't really know what the acuity of the patient is. So, I mean, you might have a -1 myope, let's say, that would may pass the test that you're doing. But if you don't do a visual acuity with it, you may not know that there's something maybe really wrong with this patient. They may have a detachment, or they may have a malignant tumor perhaps inside. So again, there's pros and cons to these techniques, but when you're doing mass screenings, sometimes if you have only one device, then you're limited as to what you can do. If you do a combination now of two things, that may change the game and story a little bit. But I'll get to that here in a little bit. So we discussed the Retinomax and the Welch-Shallon SureSight. Using the auto refractors, the first are the Retinomax and the Welch-Shallon SureSight, those devices don't flag a patient being normal or abnormal. They just tell you what their refractive status is. They might be -5 myopes, so there you go. And so if you have a situation where you're screening, hundreds of patients, you have to have something to refer to. So this table right now, table 2 that you're seeing here, was made by recommended by the American Association of Pediatric Ophthalmologists, Ophthalmology and Strabismus, pardon me. And what you can do is, let's say you get a reading from these first two devices. Let's say you get like -1 astigmatism for a patient of 45 months. So you look on the table and see whether or not that falls within a normal range. If they fall within normal, then they pass. If not, then they're flagged and referred to the ACP. So as far as using the newer devices, like the Welch-Shallon Spot and the Plus Optics, those automatically flag the patients that are abnormal. So you don't have to go look at our table or memorize the table and find out whether or not the patients are within normal limits or not. And also an advantage of these is that they are performed at a distance of 1 meter. So with shy patients and children, this tends to be a non-invasive distance. So they tend not to be as shy around you when you do that. Okay, this is the Plus Optics. This does a similar job as the Welch-Shallon does. Also, this test runs binocularly and at a distance of 1 meter. Both this device, the Plus Optics, and the Welch-Shallon Spot Screener do also give, in addition to the refractive status, they also give size of the pupils. So if there's a significant anisocoria between the two eyes, it'll detect it. These devices are battery powered. The Plus Optics, I believe, also runs on regular, like I think AA or I'm sorry, I think it's D batteries or something. So these replaceable batteries, they're not. It's not like a standard specialty battery made by a certain company that will only fit this device. So that's an advantage of having this one. And so the next device is I just wanted to touch on was the Welch-Shallon SureSight. This device is used by it's discontinued now, but it's still in use by a lot of patients, a lot of offices. And it, like the Retinomax, needs to be tested monocularly. The range of this device is less than the range that's available as terms of like an autorefraction and detecting like high prescriptions. Is much less than the RetinoMax. RetinoMax is really good for doing that. But if you're outside this range, it'll just give you an error, and you automatically know that this patient needs to be referred. But with this device and the RetinoMax, there's more work on your part. You have to look at a chart and convert and think actually whether or not this patient falls within the normal range or not. So with this is a brief overview of the RetinoMax, and as you can see, the spherical range of this in the cylinder, there's a huge. It's a very good portable autorefractor. That's what it's made for. This is the best autorefractor of the group. But again, you have to do this monocularly, and you have to get really close to the patient. So in this age, when we have an epidemic, this may not be the best device to use in mass screenings. So you have to keep that in mind. So this next group, in terms of visual acuity screening, which is the main gold standard, still is today. So this is done on ages 3 and up, and the distance vision check is what we're primarily interested in for mass screenings. It is there aren't any validated tests that say that near vision alone testing would be recommended. So you always go with what's validated, and distance vision screening is a valuable test for this, detecting whether or not the patient has normal vision. As far as distances and types of charts we're going to recall, under the age of 5, you want to make sure that your distance is about 3 meters or 10 feet, so that the patients remain focused. The recommended charts I'll get to in a second, but I just wanted to put a note on the occlusions. The recommended technique is to use actually surgical tape or hypoallergenic tape and occluder glasses. Do not have the patients hold their hands. Do not have them hold tissues, because they'll peek around and they'll cheat. A regular occluder can be used on ages 10 years and above. As far as charts, let's go to the next slide, please. What charts are recommended? The ones that are validated are the HOTV and the Leia symbol charts. Those are easily recognizable, and they have a systemic progression in size between each line. You always want to use a whole line of letters, so you want to do a crowding phenomenon. If you're going to isolate a letter, never do that unless it has crowding bars around it. Otherwise, you'll overestimate the acuity. Currently, it's the Snellen chart, the Allen chart, or the tumbling E are not recommended as charts to use. Now, that may be possible for some people, but some practices, that's all they have. So if that's what you have to get by whatever instruments are available to you. But if you're planning on it and you have the resources, then try to avoid using those charts. For children, let's go to the next slide, please. For children over the age of 6, you can use the Sloan chart, which has letters. And the distance at this point with 6 years and beyond can be 10 or 20 feet. And let's go to the next slide. So as terms of visual acuity strategies, what's the best way to do this? The traditional way was to use a threshold, start from the big letters, go all the way down to the smallest ones you can. This technique, unfortunately, wastes a lot of time. You want to use the critical line approach. So a critical line is the age-dependent line that a child is expected to see normally and pass. So you put one line, they can read it, they pass, they can't, they fail. It's that simple. The critical line acuity standards for generally about 3 years old is about the 2050. For about 4-year-olds, it's 2040, and 5 years and above, it's the 2030 to 2032 row. As far as stereopsis as being a test by itself, there is no clinical evidence to back this up. However, it can be used in conjunction with other tests. And if you're going to do one, the recommended one by Prevent Blindness was the PASS test 2. And this is a very rapid, very simple test to do. Patients wear some polarized glasses and look at 2 cards, and one of them will have a smiley face and one will not. And they just have to indicate which one has the smiley face. They are really good for 3 and 4-year-olds and over. It's an easy test to do. You just demo the cards. You show them one with a blank, one with a smiley face that they can see with the glasses, and they have to be you present them randomly 4 or 5 times, and they have to get them either 4 out of 4 or 4 out of 5 times to get credit for them. So that's an image of the PAS-2 test. And this is one discussing what a normal result would be with the PAS test too. Okay, color vision is a good idea to do as an ancillary test, but just not as a standalone test in a vision screening. So you can tag this one along with your visual acuity and your stereo test if you want to do it. And the Ishihara plate does a nice job. If you're going to have children, just if they're pre-verbal, they can trace the outline of the number using a cotton swab. Don't let them use their fingers, or the oils will make they'll cheat. Okay, so a vision screening summary. So use the optotypes that are the best studied to lay our HOTV, that use the critical line technique. The instruments that can be used tend to do a good job. Unfortunately, they don't check acuities, so you don't know how well the person is seeing. If a patient fails, rescreen them either the same day or within a couple weeks. And we discussed earlier, it's really important to establish communication with the parents and guardians regarding why it's important for their child to be seen. And having a good follow-up system from the ECP and the school system or their screening program would be really nice, so that you can make sure that patient doesn't get lost through the loops. Thank you so much for listening.
Hello there, everybody. It's Dr. Naima Ibrahim Khan here. I'm an optometry lecturer at the University of KwaZulu-Natal, which is based in Durban, South Africa. Thank you so much to Eyezone Education for inviting me to be part of this panel about vision screening, and I'd like to speak about children vision screening. Sight is so important. It is how we view the world, and it is one of the senses that a child makes use of to learn, develop, grow, explore. Okay, and we know about 80% of what they learn is actually being assimilated through their eyes. So if there's any form of vision impairment, it can therefore adversely affect a child's educational growth, and it may impact negatively on their social and cognitive development. The child naturally assumes that everyone views the world as he or she does, and thus they may not realize that they actually have a vision problem. So it's so important that competent vision screening is done early enough, especially during the early childhood years, because this will ensure that if there are any vision problems, they are detected and treated earlier, and this will improve the prognosis and improve quality of life. Teachers spend a substantial part of their day with learners and are very often the first to actually identify if there is a problem. And many researchers and public health advocates say that teachers are actually well placed to be an invaluable part of any pediatric vision screening program. What is vision screening? It's not a comprehensive eye test. A vision screening is a brief assessment that looks for potential vision problems and eye disorders that may need or may warrant a full examination. Vision screening is not used to diagnose vision problems, but it can give an indication of the possibility of a vision problem. There is often a misconception amongst the general public that a vision screening is a comprehensive eye test. And we need to advocate for vision screening overall for people to understand this difference, that it is there to actually just detect a problem, and that it is a very quick check. It's not a full comprehensive eye test. Child eye health is very close to my heart, and I'm sure very close to many vision care practitioners out there. So what is it? Child eye health is the care and treatment of children, more specifically in relation to the eye and visual health. And there are so many vision disorders that could affect children, like amblyopia, tropia, diplopia, Virgin's disorders, and even blindness. I want to speak about digital vision screeners mostly today. I find that with the advent of the digital era, most practitioners are moving away from the traditional testing methods and looking for other alternatives. Also, with social distancing coming into play, it makes sense to look at digitizing. So there are so many digital vision screeners that are out there in the world, and researchers have done such good work about it. I've just gathered up a few of them here in this presentation today. We can chat further at any point in time if anybody wants to know a little bit more about digital vision screening. But let's first look at the different categories. I've categorized it into two main ways. Some digital vision screeners only test visual acuity, or they concentrate on visual acuity, whereas other vision screeners have incorporated more tests in their battery of tests. So lots of times you find that visual acuity itself can give a good indication if there is a problem, and try to start some sort of intervention procedures because of picking up the problem. And this is probably why it's iconic, if people think about the eye test chart itself, just the Snellen chart, the lay public will think that that's an eye test, just doing a VA, they feel that that's an eye test. We as eye care practitioners know a little bit more than that, right? And we like to do a little bit more than that. But just for a vision screening, hey, this sometimes gets the job done. So let's look at some digital vision screeners that concentrated on visual acuity. The first one to speak about is the JVA screener, also known as the JVAS, and it is a computerized vision screening or visual acuity screening program, which is a software-based program, and it is able to run on any Windows-based personal computer. The next one to speak about was proposed by Lin, Law and Doe, and they proposed a portable vision screening program where the visual acuity test was converted to be viewed on a smartphone connected to a display tablet via a socket communication channel. So here, there's you find that you need a smartphone, and you need some sort of a digital device like a tablet, and the patient is able to actually run this very much on their own, where they're able to input their results or what it is that they are seeing, and this is then checked whether it's correct or not. The next one that I'd like to speak about is the PEAK school screening system. And the PEAK school screening system is doing so well around the world right now. You find that you cannot have a vision screening conversation, even just a basic conversation, without the name PEAK coming up in it. We find that researchers have used this in many countries around the world. It's called the PEAK school screening system. It tracks children as they progress through stages in the comprehensive school eye health program, and information on children requiring further examination is automatically sent to a local eye care practitioner who can provide treatment and follow-up. Parents receive an automated SMS or voice message notifying them of the screening results in their local language. It is a smartphone-based vision check app, and it allows anybody to check the visual acuity using only an Android smartphone. And this is an example here of visual acuity testing that was being performed using the PEAK Acuity application. You find that if you read any of the recent literature, the PEAK school screening system comes out with shining stars. I think it's the fact that they have such a good comprehensive system where everybody is informed along the way. There's a good track. You can go back and keep track of the kids as well for follow-up. It's a very good system to implement if you're just starting off, and if you are happy to just start off with only visual acuity. It is definitely recommended. And there are many countries who are still doing research and working with it to see if it works within their country. And I've actually only heard good things about it. other automated vision screeners that have incorporated a little bit more tests, not just visual acuity. You find, depending on the country that you are in or the area that you are in, you may want to include more testing. So here we have a few examples. One example being the VERA test, the Visual Efficiency Rating Test. It's a computer software program created for use by school nurses to screen for visual problems, including accommodative, binocular, oculomotor disorders, hyperopia, and visual acuity. So it's quite comprehensive. It's been around for a while, and it has been used quite significantly. The next school screener to speak about would be the Thompson School Screener. It was developed at City University, London, and this one can obtain parental consent, perform some vision and hearing tests, and maintain a database of screening test results. Clinical knowledge is not required to use the school screener because the screening process is managed by the software itself. So the Thompson screener as well is quite widely used. This brings me to another automated vision screener, one that I had developed as part of my own research. I called it Bona. Bona is actually a word that we use here in South Africa for some of our local languages, which means to see. Bona means to see. But it also stands for an acronym, Basic Ocular Ingane Assessment. And again, in our local tongue, if I have to say what Ingane is, Ingane means child. So it's a basic ocular children's vision of screenshots from the actual program. It's an automated software. It was developed such that children in South Africa and Africa can actually identify the targets. We found that our local South African children, some of them did not or were not familiar with some of the targets that were presented in basic children vision charts and tests. So what I had done as part of my research was to research what type of shapes or familiar figures for them, okay? And then I went through and tried to automate or digitize some of the testing that can be done, some of the basic tests that are normally done in a children's vision screening. And here in South Africa, we are regulated, the optometrists are regulated by the Health Professions Council of South Africa, and that is our regulatory body, and they have basic vision screening guidelines that we need to follow. So as an optometrist, for us to go out and say that we are doing a comprehensive children's vision screening, we need to ensure that we use the same test that they have regulated. We have to comply with the regulations for it to be called a vision screening and for it to be valid. So I had looked at the list of tests that they had recommended as part of their children's vision screening, and have included and digitized most of those tests, or all of those tests, so that we have one vision screening program that can be used in schools. At the moment, it's only available for grade 00 until grade 3. It can be changed so that it includes more grades. It's also available in 2 of our official languages at the moment, but it has the provision for more languages to be included. So it can be used not just in South Africa, but in other countries as well, if the other languages are incorporated. We are at the moment, upgrading the software, but the basic software is available and has been used in vision screening successfully thus far. It's an automated system. It doesn't need to be performed by an eye care professional because the results, it prints out a results sheet at the end, which tells you whether the patient has passed or failed the vision screening itself. So some of the tests that were included here, there was a motility test that was included. If you can left, there is a butterfly We found that in most of the primary school textbooks, a butterfly is one of the most common pictures that are depicted, and most children would actually identify with it and they know what that is. And in this case, during this test, the butterfly moves in an H pattern. And you find that by watching the patient's eyes here, you're able to see if they have smooth, accurate, and full movements in all directions. Okay, and there is a results screen which comes up as well. And if it's not safe, then you can click on that, the person administering the test. Moving along, the next test is the contrast sensitivity test. This test was modified from our Lear test, and the picture that I had used or incorporated here for the contrast sensitivity test was a bee. I promise you, the kids were very excited about seeing this test like this, seeing the bee. And here, the bee changes directions. If you can see the one at the bottom, you find that the contrast changes as well as the directions of the bee change. So that's how we know that the person who's taking, or the child that's doing the test, is able to see it. They're able to tell you the direction that the bee is flying in or facing. The next test that was incorporated into Bona is the visual acuity test. We can't have a screening without visual acuity, right? So here again, there were very many different tests, different pictures that were included. I've used a frog and a ball and a hut amongst a few. There were quite a few that we've looked through all of the common textbooks that our children here in Africa and South Africa use, and we've modified it to modify the visual acuity chart such that these are the symbols that come up so that it's familiar to the students. We found that preliminary testing, when we had used the normal charts, when they had pictures like a ship and things, those that were in the rural areas and inland areas didn't know what it was. And we were getting very poor visual acuity, and we didn't know why. But they can kind of draw it in space, they just don't know what it's called. So, the people, when the school health nurses had gone out, they found that they were recording poor acuity. But it wasn't that the child couldn't see it. They just couldn't identify, with the actual pictures. So this is why we wanted to make it familiar to our children. And we went with very nice animals and hut pictures, ball pictures, things that they can identify with. Okay. Moving along, the next test that was included was an amplitude of accommodation test, because accommodation is quite important for children. And we want to make sure, we want to screen for that if there's any accommodation issues. A TVAS was included. This is a perceptual skills test, and within South Africa, it is part of our scope as optometrists to actually perform a perceptual skills evaluation for our patients, our children, as part of a comprehensive children's vision exam. So obviously we can't include all of the perceptual tests that we know of, but I did include the easiest one, which is your TVAS. And here we're able to also pick up, from different gradings. And the program, as I said, is loaded at the moment only from grade 00 to grade 3. We can include more in the future, okay, by upgrading the TVAS scope. A word format was included. Again here, instead of using circles, we used birds, okay? And we find that our little kids like to say "inkuku," okay, because that's like the word for a chicken. But yes, they use the red greens to actually perform this test. And then the color vision test was also incorporated. And here again is the familiar butterfly in the center. Okay, overall, in general, the main factors to consider now. I thought we'd leave off the presentation speaking about the main factors to consider when you are thinking about beginning a children's vision screening or undertaking a children's vision screening, there are so many things to think about. Firstly, you want to think about the battery of tests that you want to include. This is, very much depending on the area that you're in. It could be regulated by a regulatory authority. And certainly here in South Africa, we are regulated, our profession, and therefore we have to comply with their standards. If you don't have a regulatory authority, you can look at international standards, you can look at best practice procedures, and figure out what you want to include within the vision screening. You look at the age of the child as well to figure out how to go about with the screening. Consent is very important. Remember, children are a vulnerable population. Therefore, we need parental consent as well as child consent. They need to kind of speak to them in their own way, and they need to understand what's going on. You can't just ask them to do this. Even if it means explaining to them and getting them to, they can't sign, you can just get them to put an X down if you're needing written consent as well. But consent is very important for a vision screening because it is a vulnerable population, and due to the ethics and the nature of the testing, you don't want to be caught on the wrong side of the law and ethics. Okay. Age-appropriate tests are very, very important. There are so many test options out there, and as eye care practitioners, we need to find the most age-appropriate tests to conduct that won't take too long. Because remember, it is a vision screening, it is not a full eye test. So you want it to be a quick screening so that you can do volume, you can do more people, so that if there are people, if there are children within that population that have issues, you can pick them up faster if you're actually using quicker tests, okay? Because you can see more children. The setting is also quite important, and it is something that I speak about from experience here in South Africa and working in Africa, because it depends if you are working with rural or urban children, based on whether they are in a rural setting or an urban setting. In a rural setting, you find that those children sometimes they are exposed to different things. They may not be exposed to all of the digitization that our urban children are exposed to. So we had this experience when we went out doing some vision screening a few years ago, of recent years actually, where we were screening in a rural area or a semi-rural area, which isn't too far away from the main center here in Durban. I would say it's about a 1.5 hour drive away. And we were working with primary school children, and when we went through, they were very excited, and we managed to begin. But there were a few children who started crying, and we wondered what is going on. There were some that were really enjoying the vision screening, and then these ones started crying. And then when I went over and had a chat, it turned out that it was the first time that they were actually seeing a laptop. They had never been exposed to a laptop before, so they were afraid of the laptop. So even though digitization is so important, we must also approach it with care and ensure that it is explained properly. So in that sense, I had to sit down and obviously explain to the children what it was about. I let them, there was a group of them, I let them touch it, I let them play around with it a little bit before they were comfortable enough to actually do the digital vision screening. So in that way, the setting is quite important. Whereas, if we went to an urban area, an urban school, we find there that the kids are so used to devices, they can perform it almost themselves. They're all so used to smartphones, and they know what a laptop is. They know how to use all of the functions. Also, in terms of when we speak about the setting, something else to think about when digitizing vision screening is the electricity issue. Here in South Africa, we are currently having some electricity shortages, and you don't know when the electricity is going to go off. Yes, they give you a timetable, but you're not sure. So if you are going out to a rural area, you need to make sure you have backup batteries with you, or you have a laptop that has enough battery life that can manage, because otherwise your vision screening is not, your digital vision screening is not going to work. I always suggest taking along your traditional tests and charts as a backup in case that does occur. A referral network for eye care is quite important as well. There's no point in trying to do vision screening, picking up problems, and then you're not able to actually help those that have a problem. So a referral network, within the area that you are doing the vision screening is good to establish before you even start with the vision screening. You need that backup, and you need to also have someone there who's going to watch over and ensure that the eye care needs are met for that population. Here are some references that I had alluded to during this presentation. Thank you so much for joining me today, talking about children's vision screening. I hope that it was of some benefit, and if I can be of any help, please feel free to contact me. Thank you. Take care. Bye-bye now.
Thank you so much. With that, I will immediately throw the house open for the interaction session, for the Q&A. You may either type in your questions in the chat box, or you may raise your hand and so that I can line up the questions one by one. I think Mushtaq has raised his hand for a while now. I will begin with Mushtaq. Mushtaq, you may unmute yourself and show us your video, if at all you're comfortable with that, and let us know who your question is for.
Hello, everyone. It is indeed a pleasure and honor to be a part of this wonderful session, and I thank Dr. Kovin, Naidoo, Dr. Naima, and Dr. Ali Sharifi. Been very, very helpful to gain more and more about our field. Having said this, okay, my question is to Dr. Kovin Naidoo. I mean, going by this Brien Holden study about 52% of increase in myopia by 2050. Dr. Naidoo, the thing is that study was published prior to pandemic, COVID-19. Is there any update? Because I feel like there is a disaster at the doorstep when we try to have the statistics with regard to during COVID and even post-COVID. Habit has become an obsession now, especially, I mean, looking at the figures like children who are, age 1 and 12 having a tab in their hand, and the digital screen time that it's almost doubled, and it's even tripled in some cases. And my daughter goes to the college here in Dubai, and they have told her it's going to be once in a week that she has to physically attend the college, and the rest of the week she has to be on the screen. So I feel like something big is happening, and that 2050 is too long, and something can happen very fast. Can you please enlighten us on that?
There's already it's a very good question. There are already studies that are showing that during the COVID period, myopia has increased. There was one particular study that was well done and presented the data. However, I think that we don't have an accurate projection that has not been factored into the numbers. But at the same time, remember when we factored in those numbers, we didn't have the focus on time outdoors and some of the interventions that are happening, or early eye exams, which are starting now in some societies because people are becoming more aware. So yes, COVID would impact on that number, but then concurrently at the other end, some of the interventions will start impacting. So I think it's really safe for us to kind of use a 50% marker. It's not an absolute science, but it's a good number to plan around, to work with, etc. But in short, your answer, yes, COVID has impacted on myopia. The point you raised that worries me the most is not what has happened during the COVID period. It's the behavior change that the COVID period has brought about. And that behavior change starts getting more ingrained, then that 50% is going to be about 60%, 70%. We're heading for a major crisis in the world. And we have to, as soon as COVID is used in countries, get our children back outdoors. And you know, the good news is the research is not saying that they can't work on the tablets. What the research is saying, that they must have at least 2 hours a day outdoors and exposure to light, okay? So that the dopamine stimulation can happen, etc. So I think those things are important. If anybody of us has the accurate number, no. But I think for now, till we have more of those numbers, using 50 as a marker and as a planning number makes sense. Thank you.
Thank you. Thank you for that. Snehal, I have another question to Dr. Ali Sharifi.
Sure, please go
If
ahead.
you don't mind. Yeah,
Yes.
thank you. Dr. Ali Sharifi, it was indeed a wonderful session, and I miss Kuwait, by the way. I had stayed in Kuwait for almost 11 years. And I recall my days when I used to visit the optical showrooms as a salesperson. And from that day, way back in year 2000, don't guess my age out of it, until today, there doesn't seem to be a behavioral change from the optometrist side, especially when we're treating children. You know, as the children come under the age of 12, the optometrist straightforward gives a rejection. Sorry, we cannot admit you in our clinic because you have to go to the ophthalmologist, and we can't do anything about it because it's a law from the government, from the ministry. And with being afraid of the regulations and the, you know, kind of penalties that they might receive. Is there a way out? At least there can be a minimum way forward where the optometrist can admit the children and do the minimum screening and tell them this is your problem. Beyond this, I can't do anything. And henceforth, you have to go and meet the ophthalmologist and take it on from there.
Okay, thank you for Mr. Mushtaq for that. That's a great question. Actually, a couple of questions that you had, unfortunately, optometry in Kuwait is not well regulated. I'm going to say it's not regulated at all. Maybe as countries are developing, and especially in the Middle East, maybe that will hopefully change in the future. But I mean, when you compare, like for instance, I went to school in the U.S. and optometry there is something very different than here. But that's because these countries legislate laws that allow a certain profession to have access, better access in this case, to cycloplegic agents. So you raise the bar by implementing a very good educational system, so that you treat that you're able to diagnose and refer patients that need to be referred, or treat them if you're qualified. So unfortunately, we lack that organization here in Kuwait, and maybe even along the Gulf. I don't know. I think Saudi Arabia has recently updated their optometry program, and maybe that will affect somehow the laws around these GCC, the Gulf cooperation countries. But I think that optometry as a whole in Asia, we need to do a lot more in order to be more vocal as to what we can contribute to society, and perhaps that will lead to an improvement. So to ask the second part of your question, sure, the optical shops here, even though they're limited as what they can do, they can easily do a vision screening on a patient, at least just check the acuity. And that should be relatively easy to do, especially on children that are over 6. Maybe not all the optical shops have built into their vision acuity charts picture charts or something, but they all have numbers and they all have letters, and using those to screen the children would be a great thing. They cannot treat them there under under the age of, I don't even know if this is the law in Kuwait or if this is something that's understood that they've been doing as a habit, like less than 12 or 14. I've heard different things. But I don't think it's a law that's written down somewhere where as to, this is what they can and cannot do. But doing a quick visual acuity check, you're not going to lose anything. At least you refer the patients that for sure they're not seeing correctly out. And I think that's the first step of it. And that, I think, would be better than what's happening right now currently, where you're 12 or 14, I'm sorry, you can't see you. That, I think, you had a wonderful point. I thank you for that question.
My pleasure. Thank you.
Thank you so much, Dr. Ali and Mr. Mushtaq. Is there anybody else who would like to ask questions to our speakers? The floor is open. Please feel free to interact. Okay, Mr. Ikhlas wants to ask a question, so you may unmute yourself.
I'm from Bangladesh actually, and my question is about computer-based vision screening or software-based vision screening. Actually, how much they are perfect or applicable?
Hi, hello. Hi, it's Naima here.
Hello.
To understand your question, sorry, sir, you were saying about you want to know the specificity of vision screening, of computer vision screening. Is that it?
Yes, I was asking whether computer-based vision screening are perfect enough to declare that these are clinically. What's the clinical strength of computer-based vision screening like this? And refractive, whether the refractive findings are perfect enough.
I see. Yes, so the ones that I had mentioned are all validated vision screeners. So when we do develop a vision screener, or any researcher who develops a product, they would have to go through a validation process, which is lengthy, where they see a lot of patients and they use it on a lot of patients to make sure that it is validated. And those that I have mentioned are validated screeners, and therefore their results are comparable to a traditional vision screening. And it's faster. Just to give you an example, like the one that I had mentioned, Bona, it takes about 6 minutes to actually run through the whole Bona program, which is way faster. If you have to do the same tests on a traditional vision screening, it normally takes about 10 to 12 minutes. So you can cut down time and still get, proper results at the end. Does that answer your question, sir?
Thank you, madam. Actually, I apologize. I missed that part, actually, maybe, but can you please name that specific things?
Okay, so I mentioned quite a few different programs that can be used within the presentation, but the one that I had developed was called Bona, B-O-N-A. And if you need to find out more about it, you're welcome to email me. Our website is still under construction, but yeah, you can email me. But there are many others that's out there as well.
Thank you.
Mr. Ikhlas, we will be sending you the entire video and presentation to all the registrants after the event today. Thank you for your question. And thank you, Dr. Naima, for answering it.
Thank you, moderator, to give me floor again. I'm actually asking this question to Ali Ashraf, Dr. Ali Ashraf, sir. It's about pediatric eye exam schedule. He shared a pediatric eye exam schedule, which is from American Academy of Optometry or Ophthalmology, I forgot. So there was a huge schedule. Actually, in our country, even you can get many people who didn't check their vision before they get presbyopia or something like this, some accident or something like this, where emergency need is there. So if I want to give the message to my people that within 15 years of age you have to get at least 10 or 8 schedule, people may not accept it that much. So if I want to concise or make the numbers less to some extent, so how which are the most important point of time or point of their age which is must for vision screening or eye check? Can you please, and why these are important? Can you please explain, sir?
Thank you so much, Ikhlas, for the question. So exactly, so you have to do with what facilities and that are available to you in your community. Not every community has access to care like they have in the West, for instance. And but generally, the first 3 years of life, it's really important for a child to be screened at least by their pediatrician. And most pediatricians are trained to detect ocular abnormalities. So it doesn't necessarily have to be a pediatric ophthalmologist or a pediatric optometrist, an eye care practitioner, but a pediatrician can detect basic gross deviations from the normal. Then that may need to be referred to a specialist in that case. For instance, using the Bruckner test, you can detect if the patient, and it's a basic test, if they have a mild deviation in their eyes, if they have an asymmetric refractive error, if they have a cataract. So they're well trained in performing these tests, and that's a good point. As far as the ages beyond that, I can't make up on a list on my own. These are recommendations made based on the data they had looked through numerous studies. But a good time would be right before school, I would guess. So if the first 3 years of life you check them again before schooling, that would make sense, at least to make sure that their distance visual acuities are normal. And then generally it's recommended for children to have it done every couple of years after that. So again, this depends on the resources that you have. Many of these tests can be done by the school nurses. In fact, most countries have that as a standard. Once the school starts, they have the school nurse check the visual acuity of all the kids that come in. But that again is variable. Each country has its own challenges. And each healthcare system is different. Than there are no two matching healthcare systems. So you have to use what's available to you. So in summary, I would say within the first 3 years of life to get checked, and get checked again right before school and beyond that. Thank you.
Thank you, Dr. Ali. Thank you, Ikhlas,
Thank
for
you,
the
sir.
question.
Thank you.
Anybody else with questions for our speakers? We will wait for a few moments if there are any more questions. Okay, I think with that, we have come to the end of our program today. I cannot thank enough our three speakers, Professor Kovin Naidoo, Dr. Ali Al-Sharifi, and Dr. Naima Khan, for the time and vital information that they've shared with us today. Our heartfelt gratitude to all of them, as well as our audience who have enthusiastically engaged with the speakers during the webinar. May I remind the audience that everybody who has registered will receive an email with the entire program of today. So you all can go through it once again for your information. Thank you so much, everyone. We officially end the webinar. Thank you so much.